Hello everyone, my name is Dr. Sikandar and today we will discuss about the pulmonary embolism. Let's get started. We will discuss about the introduction, then epidemiology, then what is the source of embolus, what are the predisposing factors, what is the pathophysiology, what is the clinical presentation of pulmonary embolism, then diagnostic approach to the pulmonary embolism, then risk assessment, and finally we will discuss about the management of pulmonary embolism. What is thrombus? Thrombus is a blood clot that forms in a blood vessel and remain there only. Then what is embolus? Embolus is a detached intravascular solid, liquid or gaseous mass that is carried by blood to a site distant from its point of origin. Like it is distant from its origin. It's not like thrombus. And like what is pulmonary thromboembolic disease? It refers to the condition in which blood clot, either thrombus or multiple thrombi, migrate from the systemic circulation to the pulmonary vasculature. Then we will call it pulmonary thromboembolism. And like we will discuss about this disease only. So most of these thrombi arise from the deep vein of lower extremities. So that's why we used to call it like a deep vein thrombosis. Then like DVT and pulmonary embolism can be considered a continuum of the same disease, and both are collectively referred as venous thromboembolism. So yeah, here we can see a large well-organized, this is a large well-organized embolism which is representing the cast of lower extremities vein, and it is removed from the pulmonary artery at pulmonary embolectomy by pulmonary embolectomy. So we can see like this is having like shape of lower limb, but we have like we got it from the pulmonary embolectomy. So it defined like it used to travel from the deep vein of lower limbs. Then here we can see again like chronic thromboembolic material dissected from the pulmonary arteries at pulmonary thrombo and arterectomy. And resolution of emboli is usually complete, but certain patient may left the significant emboli residual. Here we can see this is like a big emboli which is like obliterating this pulmonary artery. Then what is the epidemiology of pulmonary embolism? So like third most common cardiovascular disease after MI and stroke is pulmonary embolism. Like it is very common, and like annual incidence is uncertain. In a retrospective analysis of data involving like we have they have collected like from 2218 in all Misty country residents over 10 years period, and community residents who were not hospitalized within 90 days period had an incidence of pulmonary embolism of 3.6 per 10,000 person year. And like true incidence of pulmonary embolism is likely to be much higher since many cases remain undiagnosed. So like it is having like a good amount of incidence. Here we can see like the annual incidence rates are increasing in like US, Australia, Italy, Spain, everywhere. But like case fatality rate is decreasing because of effective treatment. So like what is the source of embolus? So like in 85 to 90% of the cases, lower extremities are the source of embolus. And like in like few conditions like pregnancy, pelvic infection, surgery, or like prostate disease, in these conditions like pelvic vein could be the source of embolus. And like in central venous catheters or intravascular cardiac devices, upper extremities can be like source of embolus, and right ventricular ventricle can be the source of embolus. And like they are telling other emboli like ear embolism, fat embolism, tumor embolism, amniotic fluid embolism, blood-borne parasite like schistosomiasis, sickle cell disease, these could be the as a these could be the as a like embolus. Then like what are the predisposing factors for pulmonary embolism? So they are telling like there is a virtuous triad which is like which clinically states predisposing to venous thrombosis. Like what is this virtuous triad? So it is having like three contents like stasis, hypercoagulability, and vessel wall injury. Like what are those conditions in which like stasis is there? Like immobility, bed rest, and like anesthesia, congestive heart failure, core pulmonary, or prior venous thrombosis. In these conditions, stasis used to be there. In hypercoagulability, it could be due to malignancy, anticardiolipin antibody, nephrotic syndrome, essential thrombocytosis, estrogen therapy, heparin-induced thrombocytopenia, inflammatory bowel disease, PNH, disseminated intravascular coagulation, protein C or S deficiency, antithrombin 3 deficiency. So these could be the cause of hypercoagulability. And vessel wall injury could be there because of trauma or surgery. So like these all conditions used to favor the venous thrombosis, and like these used to and like we used to call them virtual triad: stasis, hypercoagulability, and vessel wall injury. Then like yeah, again there he's telling like venous stasis, hypercoagulability, endothelium injury. And like now like we will discuss the risk factors one by one. So they are telling like surgical procedures without prophylaxis, risk of venous thrombosis in major surgeries 20%, and embolism after 1 to 2%, And in orthopedic surgery, like rate of thromboembolism is 50%. That is like huge. Then immobilization like paralysis, bed rest, prolonged air travel, like economic class syndrome. So in these conditions, like it used to increase risk of this pulmonary embolism used to increase. Then comes pregnancy. So like most common cause of venous thromboembolism in women younger than 40 years, risk increases five-folds during pregnancy and like 60-fold in first 3 months of pregnancy. And increase may be result of decreased mobility, pregnancy-related hypercoagulative state, like increase in factor seventh, eighth, and 10th, acquired activated protein C resistance, and like decreased free protein S level, venous obstruction from uterine compression. So these all could be like cause of increased risk in pregnancy. Then comes like oral contraceptive agents, like risk of these agents used to increase the risk of venous thromboembolism, and it is higher among user of oral estrogen containing contraceptives. The absolute risk is low and increased risk 4 to 6 folds. Then comes like hormone replacement therapy. It used to increase like 2 to 4 fold increase in the risk of venous thromboembolism. Then comes obesity. So like BMI equals to or more than 29 kilogram per meter square. Then comes like age of 70 years or older, it used to increase like 25-fold in the risk of pulmonary thromboembolism. Then comes like cancer. So like primary malignancy from lungs, breast, pancreas, prostate, GIT, these used to increase the risk 4 to 6 folds. Then comes hematological condition like polycythemia vera, essential thrombocytosis, acute leukemia. So these all used to increase the risk of this. Then comes PNH, antiphospholipid antibody syndrome, nephrotic syndrome, IVS. Again, we can see like odds ratio, like which factors increase, like which are like the factors which used to increase strongly. These are like predisposing factor for venous thromboembolism. So these are like fracture of lower limb. So here we can see like fracture of lower limb, then hospitalization for the heart failure or arterial fibrillation. Sorry, atrial fibrillation of lateral within previous 3 months. Then comes like hip or knee replacement, major trauma, myocardial infarction within 3 months, previous venous thromboembolism or spinal cord injury. So these all factors having odds ratio of more than 10%. These are like strong risk factors. Then comes moderate risk factor, which are having odds ratio of 2 to 9, 2 to 9. So these are like arthroscopic knee surgery, autoimmune disease, blood transfusion, central venous lines, intravenous catheters and leads, then chemotherapy, CHF, respiratory failure, erythropoietic stimulating agent, hormone replacement therapies, in vitro fertilization, oral contraceptives, postpartum periods, and like infection, like specifically pneumonia, urinary tract infection, and HIV, inflammatory bowel disease, cancer, paralytic stroke, superficial vein thrombosis, thrombophilia. Then comes weak risk factors, and these weak risk factors are like having odds ratio of less than 2, like which is very low. Then like which are these factors? So these are like bed rest of less than more than 3 days, then diabetic mellitus, then arterial hypertension, then immobility due to sitting, like prolonged car or air travel. Then comes laparoscopic surgery, increasing age, obesity, pregnancy, and varicose vein. So these all are like risk factors, weak risk factors. Then comes like inherited risk factors. So factor 5 laden mutation, most common inherited predisposition. This is like most common inherited predisposition, and single point mutation on factor 5 gene resulting in factor 5A with diminished sensitivity to the natural anticoagulant effect of active protein C. Then comes prothrombin gene mutation. So they are telling like 3 untranslated region of prothrombin gene, like substitution of A for G at the position of 20,210. So like this is like exact position. This mutation result in an overproduction of prothrombin, which is otherwise normal. Okay, guys. So in clinical practice, like factor 5 laden mutation and prothrombin gene mutation are the most common inherited conditions and account for more than half of the cases of inherited thrombophilia related venous thromboembolism. Very important. Then comes like antithrombin 3 deficiency. It can lead to like venous thromboembolism, then protein C and S deficiencies. Then comes like pathophysiology. The physiological effect and clinical consequence of the pulmonary thromboembolism vary widely, ranging from asymptomatic disease to hemodynamically collapse, and it can also lead to death. Then they are telling like major factors that determine the outcome. These include like what is the size and exact location of emboli, coexisting cardiopulmonary disease is there or not, then secondary humoral mediator release or vascular hypoxic response, and the rate of resolution of emboli. So these all are the factors that define the prognosis. Then like what are the hemodynamic consequences? So they are telling like obstruction of pulmonary vascular bed by embolism acutely increases right ventricular afterload. So in the absence of pre-existing cardiopulmonary disease obstruction of less than 20% of the pulmonary vascular bed, it results minimally hemodynamic consequences, like it is not that much. But when the degree of pulmonary vascular obstruction exceeds 30 to 40% and modest increase in right ventricular pressure occurs, but cardiac output is maintained by increasing in the heart rate and myocardial contractility. So till this stage, like a patient is stable. But compensatory mechanism begins to fail when degree of pulmonary artery obstruction exceed 50 to 60%. Like 50 to 60% of the pulmonary arterial bed is obstructed. In these conditions, like compensatory mechanism will not gonna work, and like cardiac output begins to fall and right atrial pressure increases dramatically, and patient can collapse. So we can see like this is a very good diagrammatic representation of this whole consequences. So like initially increase right ventricular afterload, then right ventricular dilatation will occur, then it will lead to uh, tidal volume insufficiency, then right ventricular wall tension will increase, then neurohormonal activation, myocardial inflammation will be there, then right ventricular oxygen demand will increase, which will lead to right ventricular ischemia, and right ventricular contractility will reduce, which will lead to decrease in decrease in output from the right ventricle, which will lead to decrease left ventricular preload, which finally lead to low cardiac output, and systemic blood pressure will decrease, and right ventricular coronary perfusion will decrease, right ventricular oxygen delivery will decrease, and this will lead to finally cardiogenic shock, and finally patient can die. So this is the whole consequence from initiation to the end. So, what are the gas exchange abnormalities in pulmonary embolism? So, they are telling like hypoxemia is the most common immediate physiological consequence of pulmonary embolism. Very, very important. So, like hypoxemia is the most common and immediate physiological consequence. And increase in ventilation perfusion inequality, like it will, like ventilation will be there, but like perfusion will not be there. And intrapulmonary shunting will be there, and decrease in mixed venous oxygen level, which will lead to like alveolar hemorrhage, or atelectasis related to loss of surfactant also causes shunting and increase in the alveolar dead space. Despite an increase in alveolar dead space, patients with pulmonary embolism often develop hypocapnia. This is due to hypoxia-induced intrapulmonary reflex vagal stimulation, with resulting in hyperventilation. So like CO2 will wash out. Then comes like pulmonary infarction, very uncommon because the pulmonary parenchyma has three potential sources of oxygen. So what are those sources? Like pulmonary artery will be there, bronchial arteries are there, and airways are there. So like oxygen, patient will get the oxygen. Still, it can occur, like rarely it can occur. So like two or three sources apparently must be compromised before infarction develops. So like it is rare, it means. So what is the clinical presentation of pulmonary embolism? The presentation of acute pulmonary embolism can be categorized into one of the three clinical symptoms. Like first thing is like isolated dyspnea will be there, very very important. Like isolated dyspnea can be occur. Then pleuritic chest pain or hemoptysis can be there, and then like circulatory collapse will be there. Two additional mode of presentation are also possible, like subclinical clot and chronic non-resolving or propagating clot could be there. So like they are telling like what are the symptoms. So dyspnea, and dyspnea like dyspnea is the most common presenting symptoms, very very important. So dyspnea will be the most common presenting symptoms, so we should remember this thing, very very important. Then sudden, it will be like sudden onset, it will be usually in the rest and may be noted with exertion. So this is like dyspnea. And then pleuritic chest pain, cough, hemoptysis, leg swelling or pain could be there. Then what will be the signs? Very very important. Unexplained tachypnea will be there, very very important. So this is the most common sign, like unexplained tachypnea. And other findings are like rails, tachycardia will be there, increased pulmonary component of second heart sound because of involvement of right ventricle. So these things should be there. Then comes the incidence of sign symptoms of pulmonary embolism. So they are telling like tachypnea is like uh, most common. Like in massive pulmonary embolism, it used to be occur in 95% of the cases. In submassive pulmonary embolism, in 87% of cases, and like without pre-existing cardiopulmonary disease, in 70% of cases, it used to be there. Like tachypnea is very very common. Like most common sign is tachypnea. So we should remember this thing. Like tachypnea is most common sign, and like dyspnea is the most common symptom. Like it used to be there in 85% cases of massive pulmonary embolism, and 82% cases of submassive pulmonary embolism, and 73% of the cases of without pre-existing cardiovascular disease. Then comes like pleuritic chest pain, cough, hemoptysis, increased pulmonary component of second heart sound, rales, phlebitis. So these things also used to be there. Then comes like how we will do clinical assessment. So to know the pre-test probability of the disease, we used to do this. This pre-test probability aids in the selection and interpretation of the further diagnostic test to create a post-test probability of the disease. This post probability can then be used as a basis of clinical decision making. So like what is this like clinical prediction score? Like the Wells score is very common and like most commonly used score. So there are like total uh, 7 components are there. So we will give like 3 points to if there are like DVT sign symptoms are there and pulmonary embolism is likely or more likely than alternative diagnosis. Like there is no alternative diagnosis, we are suspecting like it is mostly due to pulmonary embolism, and there are sign symptoms of DVT. Then we will give three points to both of them. Then comes like there are 3 points which are having like 1.5 points. So like if heart rate is more than 100, if there is history of immobilization or surgery previously in within like 4 weeks, then we will give it 1.5 points. And there is like previous DVT or pulmonary history of like previous DVT or pulmonary embolism, then also we used to give it 1.5 points. So then like comes hemoptysis and malignancy. So we used to give it only 1 point if patient is having history of hemoptysis or malignancy. So yeah, very very important. So like they are telling if total score is less than 2, then like this is like it will define like there is low probability of pulmonary embolism. If like test score is 2 to 6, then patient is having moderate risk of pulmonary embolism. If like more than 6 score is more than 6, then like it is like highly probability like it is pulmonary embolism only. And there is another score which is like dichotomized score. According to that, like if score is more than 4, then it is likely to be pulmonary embolism. It is if it is 4 or less than 4, then it is unlikely pulmonary embolism. Then comes like laboratory findings. So they are telling like modest leukocytosis may accompany embolism, but rarely it can also exceed 20,000. In AVG, there will be like low partial pressure of oxygen, low partial pressure of CO2, very, very important. Like both of them will be reduced. And there will be high uh, arterial and alveolar gradient will be high. Like alveolar and arterial jo gradient hai, it will be high. Then they are talking about the ECG. So ECG is like non-specific finding, and like uh, if S1Q3 T3 pattern is there, then it is specific for pulmonary embolism only. Very, very important. And that it is seen only in a minority of the patient. The presence of S1Q3 T3 pattern, right bundle branch block pattern, or T wave inversion is there in lead V1 or V3 in a patient with pulmonary embolism should suggest the presence of right ventricular dysfunction. So then we can tell it like it is because of pulmonary embolism. And other clinical disorder MI could be there. So here we can see like S1 is prominent in lead 1, like S wave is prominent in lead 1, then Q wave is prominent in lead 3, and T wave inversion is there. So we can see this is the T wave inversion. So T wave inversion will be there in lead 3 only. So this is S1Q3 T3 pattern. Then comes like chest X-ray, like chest radiography. So they are telling like it is abnormal, but it is not specific. So what are the findings? Like atelectasis could be there, pleural effusion, like small and involve only blunting of the costophrenic angle. And then they are telling like pulmonary infiltrate, abutting a pleural surface can be of any shape, not necessarily wedge shape. So pulmonary infiltrate could be there. Mild elevation of hemidiaphragm could be there to exclude alternative diagnostic possibilities such as pneumothorax. A normal chest radiograph in a patient with otherwise unexplained acute tachypnea, dyspnea, or hypoxemia should raise the possibility of pulmonary embolism. Then they are telling like this is the Hampton's hum. Hampton's hum sign, a dome-shaped pleural-based opacification of the lung is there. So this is the Hampton's hum. Like this is actually a wedge-shaped opacity which is present in like periphery of the lung, and it is known as Hampton's hum. Then there is like Pallage sign, which is like enlarged right descending pulmonary artery. So this is the Pallage sign. This is the prominent right descending pulmonary artery. What is the Westmark sign? Westmark sign is like peripheral hyperlucency secondary to oligemia. So because of like blood supply is reduced in the right lung, so we can see this is like peripheral hyperlucency. Then they are talking about the again we can see like this is the Pallage sign which is having a prominent right descending pulmonary artery. Then like what is the role of D dimer? So they are telling like D dimer it is highly sensitive, but it is not specific, and the negative predictive value of D dimer test is high. Increased level are present in nearly all the patient with venous thromboembolism. They are telling like false positive could be there like in case of advanced age, pregnancy, trauma, infection, post-operative period, inflammatory state of malignancy. And like it is we can check it by ELISA, latex agglutination, or red cell agglutination. Then they are telling like age adjustment like cutoff value in the elderly. It is like age into 10 microgram per ml above. Like we should minus whatever the value is there. We should minus it from the age into 10 microgram per ml above 50 years of age. Like suppose a patient is having like age of 60 year, then we should directly minus 600 from whatever value we are getting. So that is the age adjustment. Then comes like D-dimer cutoff adapted to clinical probability. So here we can see this is very important. Like according to years items, like years criteria is having like 3 items totally out from the Wells score only. So if there is a case which is if patient is not pregnant and like from the years items like there is clinical sign of DVT or hemoptysis or pulmonary embolism, most likely diagnosis is there. Then out of these three, if score is 0, like none of these is matching, then like we should perform D-dimer test. If D-dimer is less than 100, sorry, less than 1000, then it means pulmonary embolism is not there. If D-dimer is more than 1000 and like there is no years criteria is matching, then we should order for CTPA. If any of these one like years criteria is matching, then like we should perform D-dimer, and if D-dimer is like less than 500, then we should exclude the pulmonary embolism, like it is not because of pulmonary embolism. If like score is more than 1 or more than 1 and like D-dimer testing is like having more than 500 nanogram per ml, then we should order for CTPA. If out of these like years items any one of them is positive and like D-dimer is more than 500, then we should order for CTPA. If none of them is there, then like it should be like level D-dimer level should be 1000 to order for CTPA. Then like in pregnancy, what is the algorithm? So like that, like if pregnant patient come to you, then we should evaluate for clinical sign of DVT are present or not. If they are present, then we should perform compression ultrasonography of symptomatic leg. If it is normal, then we should proceed for like according to non-pregnant guideline. Like here, this thing is very important. Like to performing compression ultrasonography of symptomatic leg, very important. So this thing is very important here. If it is abnormal, then we should directly initiate the anticoagulation treatment. There is no need for D-dimer if compression ultrasonography of symptomatic leg is positive. Then comes like ventilation perfusion scanning. So they are telling like it is early pivotal diagnostic. Now it is replaced by CT imaging. So situation in which like we can order ventilation perfusion scanning and like it is preferred over CT pulmonary angiography. So these conditions are like severe iodinated contrast. If patient is having like allergy to the contrast, like we can't use contrast for those patients, then we should perform ventilation perfusion scan in those patients. If renal dysfunction is there, if a critically ill patient to whom transportation to CT scanner may be deemed to high risk, or if patient is like pregnant, then in all of these cases like ventilation perfusion scan is preferred. A negative study is capable of ruling out of the diagnosis of pulmonary embolism with the same degree of certainty as a negative pulmonary angiogram and with higher degree of certainty than can be achieved by negative CT scan. Very important. So they are telling like negative predictive value is equals to CT scan. So like we can perform ventilation perfusion scan if patient cannot go for CTPA. The positive predictive value for high probability study by multiple segmental size mismatch defect, they are telling it is approximately 88%. When this coupled with high clinical probability of if patient is having like sign symptoms of pulmonary embolism and we are performing like ventilation perfusion scan, then positive predictive value can increase till 96%. Very important. Then there are like some criteria which are rule out criteria for pulmonary embolism. So for that we have to see like what is the age of the patient. If it is more than 49 year of, if pulse rate is more than 99, pulse oximetry is having like less than 95% saturation. Does the patient have current hemoptysis? Like currently patient is having hemoptysis or not? Is the patient taking exogenous estrogen? Does the patient have history of venous thromboembolism? Has the patient had surgery or trauma requiring hospitalization in the past 4 weeks? Past 4 weeks. Does the patient have unilateral leg swelling? So out of these all criteria, like these are approximately these are total 8 criteria. If out of them all are having answer no, then we can rule out like it is not because of pulmonary embolism. This is very important. Then this is like ventilation perfusion scan. Here we can see like involvement of this is the involvement of right, middle, and lower lobe. Like wherever like blood supply is not there, we can suspect like it is because of emboli in the pulmonary artery. Then comes like echocardiogram, like 2D echo. So that like overall sensitivity is approximately 50%. Sensitivity and specificity exceed 90% in the detection of the proximal emboli involving the pulmonary trunk and the right and left pulmonary arteries. Overall of all the arteries, it is 50%. Risk assessment and treatment guidance, they are telling like on TT, right ventricular dysfunction, an independent predictor of an adverse outcome of early death. So like in thromboembolism, if right ventricular dysfunction is there, then it is like not a good thing actually. And evaluation for right ventricular infarction, endocarditis, pericardial tamponade, or aortic dissection, we used to perform 2D echo. So yeah, McConnell sign is there, which is present in what is this? This is actually akinesia of mid-free wall of right ventricle. So here we can see like this is the right ventricle. Here we can see, and it is having like reduced motility at the apex of right ventricle. So this is the akinesia of mid-free wall of right ventricle. Very, very important. So this is the McConnell sign, which is present in because of right ventricular dysfunction, because of this pulmonary embolism. Very, very important. So for lower extremities evaluation, like we used to perform duplex ultrasonography. It is the combination of Doppler venous flow detection and real-time beam mode imaging. So what is the criteria? Like non-compressibility of venous segment should be there. If it is there, then we will think about like it is because of DVT. Presence of echogenic material within the venous lumen, loss of phageity with respiration, attenuated increase in venous diameter in the response of Valsalva, and lack of augmentation of flow in response to calf compression. Like we are compressing the calf, still like there is lack of increase in the flow. They are telling like sensitivity and specificity is 95% in the symptomatic case with proximal DVT. Very, very important. Then comes like CT venography appear to comparable to ultrasonography with respect to sensitivity and specificity. So like ultrasonography is having like very high sensitivity and specificity. It requires contrast injection with associated risk and radiation exposure. So with CT venography, like it is having it requires actually contrast injection, and like it is also having risk because of contrast and radiation exposure. Advantage of CT venography is ability to visualize the pelvic vein and the vena cava. So like combined CTP and venography, they are telling visualization of embolus and its source in a single study. So that's why this combination is good. Potentially, it increase diagnostic yield, increase expense, substantial pelvic radiation exposure, and risk of hemorrhagic complications are there. Then they are telling about the MRI. The sensitivity and specificity of MRA among patients with technically adequate scan was 78 and 99%. Like specificity is very high, but sensitivity is little low. Alternative in like IV contrast allergy, like we can use MRA if patient is having contrast allergy or in whom avoidance of radiation is required, like pregnancy. So in case of pregnancy or contrast allergy, we can use MRA. Then comes CT scan. Like CTPA has become the first line imaging test for pulmonary embolism. Like we used to perform the D-dimer testing, and then directly we used to go for CTPA. Very, very important. So CT scan can be considered confirmatory in the excluding embolism in patient with a low or intermediate likelihood of disease, and confirming embolism in patient with intermediate or high probability of disease. Very, very important. So we should perform it. When discordance exists between the clinical assessment and the CT finding, additional studies should be considered. So they are telling like Polomint sign, railway track sign, peripheral intraluminal filling defect used to be there. So these are the signs which are present in CT of this thing. So guys, what is the Polomint sign? This is the Polomint sign. We can see. So yeah, here you can see this is the Polomint shape, and like here, the emboli is in within the pulmonary artery, and this is looking like Polomint. And again, here we can see this is the Polomint sign, and this is the Polomint sign. And like there is another sign which is known as railway track sign. So here we can see inside the pulmonary artery there is like emboli. So this pulmonary embolism is there, and it is looking like railway track. So this is the intraluminal filling defect which is seen in the pulmonary embolism. Again, we can see this is the saddle shape pulmonary emboli inside the pulmonary at the division of pulmonary artery. This is the heart. It is representing right heart. This is representing left heart. So normally, like left heart diameter is more than right heart, but here we can easily see this right heart diameter is more than left heart diameter, and this is the septum is normally this is not like this. It used to be like this, but it is straight, and like this is the D-shaped lumen of this right ventricle. Very, very important. So it used to happen in the because of right ventricle failure or increasing diameter of left right ventricle in pulmonary embolism. Again, we can see this is the emboli inside the pulmonary artery. So like After CT, what is like conventional pulmonary angiography? So angiography reserved for a small subset of the patient on whom diagnosis of pulmonary embolism cannot be established or excluded by less invasive means, and the evaluation of suspected chronic thromboembolism is required. Only two angiographic findings are diagnostic of acute embolism. First is there should be a filling defect and there should be abrupt cutoff of a vessel. Very, very important. One is accessibility and the need of transportation which is required during this procedure, and limitation is interpretation which is influenced by three factors. First is the location of thromboembolism obstruction. So if it is like in major vessels, so it can be easily seen, so there is no that much problem. But if it is in periphery, then yeah, it does matter. Then quality of image, it does matter a lot, and the experience of the interpreter. Then here we can see this is the pulmonary angiography, and we can see this pulmonary left pulmonary artery and like its branches. So, what is the diagnostic algorithm for acute pulmonary embolism using the Wells criteria? So we know like this is the Wells criteria, and according to Wells criteria, we can uh, classify patients into three categories. First is high probability, then intermediate, then low probability. So what is the Wells criteria? We know easily like uh, we can give 3 points to two things. First is like clinical sign and symptoms are suggestive of DVT. Then we will give 3 points. And pulmonary embolism is number one diagnosis or equally likely, and there is no other diagnosis is there. Then we will give 3 points. If heart rate is more than 100 and history of immobilization in past 3 days, or there is history of surgery in previous 4 weeks, then we will give 1.5 point. If there is previous history of pulmonary embolism or DVT, then we will give 1.5 point. Then to hemoptysis and malignancy, we will give 1 point. So out of these 12.5 scores, if uh, more than 6 score is there, then it is high probability of pulmonary embolism. If 2 to 6 score is there, then it is intermediate. If it is less than 2, then it is low probability of pulmonary embolism. So we will discuss these all the flowcharts in next 3 slides. So this is the high probability of pulmonary embolism. Wells score is more than 6. Then we will see if CT pulmonary angiography is feasible or not. If it is feasible, then we will do CT pulmonary angiography. If like clot emboli or clot is there, then it is positive and pulmonary embolism is diagnosed. If it is negative, then pulmonary embolism is excluded. Very important. If it is inconclusive or CT pulmonary angiography is not feasible, then we will go for ventilation perfusion scanning. Very, very important. And in ventilation perfusion scanning, is it available or not? If it is not there, then further testing is warranted. If it is normal, then pulmonary embolism is excluded. If it is having high probability, ventilation perfusion scanning is having high probability, then pulmonary embolism is diagnosed. If it is having lower intermediate probability, then further testing is warranted. So if BP is not available, then also further testing warranted. If it is having lower intermediate probability, then also further testing is warranted. Then comes intermediate probability of pulmonary embolism. So like Wells score should be between 2 to 6. Then in these cases, we will check like D dimer level. If D dimer level is less than 500, then pulmonary embolism is excluded. If D dimer level is more than 500 nanogram per ml, then we will go for CTPA. If CTPA is in CTPA, like it is positive, then it is diagnosed. If it is negative, then it is excluded. If it is inconclusive or CTPA is not available, then we will go for ventilation perfusion scan. If it is positive, then it is diagnosed. If it is yeah, if it is like normal, if it is normal, then it is like excluded. Pulmonary embolism excluded. If it is not normal, like then further testing is warranted, or it is like not available. It is not available, or it is like not normal in both of them cases. Then we will go for low probability pulmonary embolism. Very important. Like Wells score will be less than 2. So here in this low probability, we will check like is can pulmonary embolism rule out criteria be applied or not? If it is applied, then we will rule out the. There are like certain points. There are 8 criteria are there. If all of them are like there or not, we will check it. These criteria are very, very important. It is applied only in a low probability pulmonary embolism risk. So age should be less than 50 years, heart rate should be less than 100, such oxygen saturation should be less than 90%, no hemoptysis, no estrogen use, no prior DVT or pulmonary embolism, no unilateral leg swelling, no history of trauma or surgery requiring hospitalization within the past 4 weeks. So if all these criteria are met, then it is excluded that it is not pulmonary embolism and further testing is required. If out of them one is positive, then also we can't apply this criteria, then we will go for D dimer testing. And in D dimer, level of D dimer is less than 500, then pulmonary embolism is excluded. Or if D dimer level is more than 500, then we will go for CTPA. If in CTPA, it is positive, then it is diagnosed; it is negative, it is excluded; it is inconclusive, or CTPA is not feasible, then we will go for ventilation perfusion scanning. If in ventilation perfusion scanning, like it is normal, it is available and it is normal, then pulmonary embolism excluded. If it is not normal or if it is not available, then further testing is warranted. Very, very important. So these three flowcharts were there according to Wells score, according to D-dimer, CTP, and VP scan. So now we will go for severity and the risk of pulmonary embolism. So initial risk stratification is based on clinical symptoms and sign of hemodynamic instability. So without hemodynamic instability, further risk stratification require assessment of two sets of prognostic criteria. First is clinical factors. We will see imaging and laboratory indicator of pulmonary embolism. Second is presence of comorbidity or any other aggravating condition is there or not. So yeah, we can divide pulmonary embolism into three parts: non-massive, submassive, or massive. So in non-massive, like incidence of non-massive is 75%. Like it is more, like most of the cases are non-massive only. So what is the definition of non-massive pulmonary embolism? So absence of hypotension and right ventricular dysfunction and myocardial necrosis. Like there, none of them is present. Then we will tell it like this is non-massive. And shock will not be there. PASI score will not be more than one. Imaging with right ventricular dysfunction will not be there. Cardiovascular marker will be normal, and mortality in non-massive pulmonary embolism will be less than 1%. Very, very important. So this is the least likely, like most of the cases are of non-massive only, it is having like very less mortality rate. Then we will come to submassive. So in submassive cases are like remaining 20 to 25% cases are submassive. So what is submassive pulmonary embolism? This is very important criteria. So systolic blood pressure will be more than 90 mm Hg, and out of these two things, one will be positive. Either like right ventricular dysfunction by imaging, like in 2D co, this CT or in CT, like right ventricle is to left ventricle ratio will be more than 1. Means like right ventricle will having more diameter than left ventricle. Or positive biomarkers like elevated pro-BNP or elevated like positive troponins will be there. Then or shock is not there and PASI score will be more than 1. In imaging, right ventricular dysfunction is there. Either one could be positive or both of them could be positive. If either is positive, then like it is having intermediate risk of less than 5%. If both of them are present, like then it will have like high probability, like 10% chances of mortality will be there. If it is massive pulmonary embolism, which is like in least of the cases, like less than 5% of cases are of massive pulmonary embolism. And how we will diagnose it? Very, very important. Systolic blood pressure will be less than 90, or drop in systolic blood pressure greater than 40 mmHg for longer than 15 minutes, or there will be obstructive or cardiac shock. Like shock will be the prominent feature of this massive pulmonary embolism. Very, very important. And PASI score, obviously it will be more than 1. And imaging dysfunction will be there. Cardiac biomarker will be positive, or and like mortality rate will be like more than 25%. Like it will be very high. Like out of 4 cases, 1 case will die. Very, very important. So this is the massive pulmonary embolism. So now we will discuss about the clinical imaging and laboratory indicators. So in clinically, acute right ventricular failure will be there, which is the most important parameter. Very, very important. So acute right ventricular failure, tachycardia will be there, low systolic blood pressure will be there, respiratory insufficiency means tachypnea will be there, low oxygen saturation will be there, and syncope will be there. In 2D echo, right ventricle upon left ventricular diameter ratio will be more than 1, and TAPSE will be less than 16 mm. Then in CTPA, right ventricular enlargement will be there. Right ventricular end diastolic diameter and right ventricular upon left ventricle ratio will be measured in transverse or four-chamber view. Volumetric analysis of the heart chambers and the assessment of the contrast reflux in the IVC, and these all things will be higher in CTPA. And like marker of myocardial injury, like cardiac troponins, heart type fatty acid binding proteins will be elevated. Marker of right ventricular dysfunction, like uh, this FB type natriuretic peptide and N-terminal pro-BNP, like anti-pro-BNP, and this FB type natriuretic, this BNP will be higher. Other laboratory parameter means lactate will be higher side. Elevated serum creatine level and decreased glomerular filtration rate, elevated neutrophil gelatinase associated lipocalin, very very important. Neutrophil, these are like recent new markers are there. Elevated neutrophil gelatinase associated lipocalin and cystatin C and copeptin. These will be elevated in this pulmonary embolism. Then what is the simplified PASI score? Very, very important. It used to assess the mortality risk. So it is having total 6 points. PASI score, simplified PASI score is having total 6 points. First point is age of more than 80 years. We will give 1 point. Like every point of every one of them is having 1 point only. So age more than 80 years, history of cancer, chronic cardiopulmonary disease is there, chronic cardiopulmonary disease is there, pulse rate is more than 1110 by 1110, systolic blood pressure is less than 100 mmHg, arterial oxygen saturation is less than 90. So this is like 1110, then 100, then 90%, then 80 year of age. Then comes like history of cancer and chronic cardiopulmonary disease. Again, I am repeating it. Age more than 80 years, history of cancer, chronic cardiopulmonary disease, pulse rate of more than 1110, systolic blood pressure less than 100, arterial oxygen saturation less than 90%. Then if score is 0, then 30 days mortality is only 1.1%. If score is either 1 or more than 1, then 30-day mortality rate will be 63.8%, which is very high, very, very important. This is simplified PASI score. Then comes to Hestia criteria. What is Hestia criteria? Like either we should admit the patient or not. So if out of these any is like yes, then we should admit the patient. So there are total 11 points. First is either patient is hemodynamically stable or not. Then thrombolysis or embolectomy required. Active bleeding and high risk of bleeding is there. Oxygen saturation more than we need oxygen supply to maintain oxygen saturation for more than 90% for more than 24 hours. Pulmonary embolism diagnosed during anticoagulant treatment. In severe pain needing IV pain medication for more than 24 hours required or not. Medical or social reason for treatment in hospital more than 24 hours. Creatinine clearance less than 30 ml per minute. Severe liver impairment or disease is there or not. Each patient is pregnant or not. Documented history of heparin-induced thrombocytopenia is there or not. So these all are 11 points. Then we comes to management part of this pulmonary embolism. So first, like what are the goals? So adequate oxygenation should be there. Hemodynamically stable patient should be. We should give the hemodynamic support to the patient and to prevent thrombus propagation, which is already developed, and to prevent emboli recurrence. So oxygen therapy and ventilation, administration of supplemental oxygen is indicated in patient with pulmonary embolism and saturation is less than 90%. When feasible, non-invasive ventilation means NIV or oxygen through a high flow nasal mask should be preferred. In mechanical ventilation, positive intrathoracic pressure induced by the mechanical ventilation may reduce venous return and it can worsen low cardiac output due to right ventricular failure in patient with high risk of pulmonary embolism. So we should avoid this this mechanical ventilation or in high risk of pulmonary embolism. And they are telling like tidal volume of approximately 6 liter per kg lean body weight and inspiratory plateau pressure should be less than 30 mm of water should be there. So first thing is how we will manage acute right heart failure in patient with high risk of pulmonary embolism. Like patient is having high risk of pulmonary embolism or patient is having acute right ventricular failure due to pulmonary embolism, then how we will manage that patient? So strategy will be like volume optimization is required, vasopressor or inotrope we have to give, then mechanical circulatory support should be provided. So yeah, so they are telling first thing is volume optimization, volume loading, saline or ringer lactate should be given with the rate of more than 200 ml within like 15 to 30 minutes. And consider in patient with decompensated right ventricular failure or normal central venous pressure or low arterial pressure is there, then we should give this volume loading. But the disadvantage is like volume loading can overdistend the ventricles and it can worsen ventricular interdependence and reduce cardiac output. Very, very important. Then comes vasopressors and inotropes. So like we will prefer norepinephrine with the rate of 0.2 to 1 microgram per kg per minute. Very, very important. Or dovutamin we can give 2 to 20 microgram per kg per minute. So like they are telling like they used to increase inotropy and like maintain the systemic blood pressure, promote positive ventricular contraction, and restore coronary perfusion gradient. And like excessive vasoconstriction may worsen the tissue perfusion obviously and may aggravate arterial hypotension if used alone. So we should not use this dobutamine alone without a vasopressor, especially if left heart failure is present. We already know about the dobutamine. Then they are talking about the mechanical circulatory support. So ECM or ECLS, like we can give, or like percutaneous catheter method, microaxial pump we can provide, or paracorporeal RVADS we can give. So what is this ECMO? ECMO is extracorporeal membrane oxygenation, and ECLS is extracorporeal life support. So like what is the use? So they are telling like short-term support we can provide. These are cost-effective and they can like rapid oxygenator can be added in them. But like complication with the use over longer period, like if we are using them for more than 5 to 10 days, then they have a lot of complications and limited pump capacity. These percutaneous catheter method, microaxial pumps having like limited pump capacity, and ECLS preferred in severe cardiogenic shock or where high pump flow required. And this paracorporeal RVADS, what is this RVADS? Right ventricular assist device. So these are appropriate for longer term use, like weeks or months. Can be combined with oxygenator when pulmonary support is also needed. So this is like acute right ventricular failure management in case of high risk of pulmonary embolism. So yeah, now we will proceed to the drugs. So first is like heparin. So they are telling like it is the standard initial therapy, very, very important. Heparin is the standard initial therapy. It is indirect thrombin inhibitor. It used to act by antithrombin 3 and it inactivate second day, 8th, 9th, 10th, 11th and 12th. All of these factors it used to inactivate and reduce the thrombosis by antithrombin 3. And low, it is having two types: low molecular weight heparin LMWH and unfractioned heparin. Two types are there. So first we will study about the low molecular weight heparin. Low molecular weight heparin are preferred over unfractioned heparin. Very, very important. So these are preferred for initial anticoagulation in pulmonary embolism. So what are the advantage of low molecular weight heparin? So they are telling me it is having longer half-life and it is very easy to use. Ease of use is very good and longer half-life is there. Then ability to consistently achieve early therapeutic anticoagulation. This is like very important point. So we can achieve early therapeutic anticoagulation with the help of low molecular weight heparin. Then there is no need to monitor anticoagulant effect. Very, very important. So there is no need to monitor the anticoagulant effect in case of low molecular weight heparin, and reduce incidence of major bleeding complication or heparin-induced thrombocytopenia. Like these side effects are very less, and there is no need for monitoring. Also, it is having early. We can achieve early therapeutic anticoagulation and lower half life. Sorry, longer half life is there and eased for use. So like all points are favoring in case of low molecular weight heparin. So obviously we should use LMWH. So they are telling like long-term use in pregnancy and active cancer, we can use this LMWS. So they are telling about the anticoagulation with heparin remains the standard initial therapy for hospitalized patient. I have already talked. It reduces thrombus propagation, prevent embolic recurrence. Choice include unfractioned or low molecular weight heparin. Given that failure to achieve rapid therapeutic level of anticoagulation appears to be associated with an increased recurrence, it is important to ensure adequate anticoagulation as soon as possible. So we can achieve it with subcutaneous LMWH preparation. One commonly employed dosing regimen using, so we will discuss it later. Okay, guys. So yeah, therapeutic monitoring when it is required. So yeah, so they are telling like patient with anti-phospholipid antibody or other circulating anticoagulants who have elevated baseline APTT. So in these conditions only we required therapeutic monitoring of LMWH. Then comes like extreme of body weight, like either patient having very less body weight or very high body weight, like either less than 40 kg or more than 150 kg. Then we need therapeutic monitoring. Then comes like significant renal diseases there, like creatinine clearance less than 30 ml per minute is there. Then we need to therapeutic monitoring of LMW. Then if patient is pregnant or like he's having unexplained bleeding or recurrent thrombosis is there, then obviously it is required. Then they are telling like monitoring with anti-10A levels. Okay, guys, anti-factor 10A levels. So we used to monitor it with this level of factor 10A. Therapeutic target range for peak anti-10A level ranges from 0.6 to 1 international unit per ml after 4 hours of administration. So like level of factor 10A, anti-factor 10A should be like 0.6 to 1. And they are telling in enoxaparin to be greater than 1. It should be like more than 1. Then they are talking about the unfractioned heparin. So situation in which the use of unfractioned heparin is required. So the patient is having renal insufficiency, very very important. So in case of renal diseases, we used to prefer unfractioned heparin over low molecular weight heparin, very very important. Or if patient is having extremes of body weight or circumstance in which rapid adjustment or reversal of anticoagulation is needed, like a woman is in the late stage of the pregnancy whom cesarean section is needed, so in those cases, unfractioned heparin is, should be given. Patient with recent surgery or recent history of bleeding is there. Hemodynamically unstable patients are there with venous thromboembolism who may need surgical procedure in like emergency surgical embolectomy is required, may require like within 2 3 days. So we should prefer unfractioned heparin in those cases, like renal insufficiency, extreme of body weight, in the circumstance where rapid adjustment is needed, or like recent surgery or recent bleeding history is there, or in future we need surgery. So like how we used to give unfractioned heparin. So initially intravenous bolus of 80 unit per kg we have to give. Like if patient is having body weight of like 40 kg, then obviously we should give like around uh, 30 to 100 of 30 to 100 of like unfractioned heparin. Then continuously we will give with the rate of this 18 18 unit per kg per hour, with the rate of 18 unit per kg per hour. And they are telling like how we will monitor this unfractioned heparin. Like we used to monitor LMWH with the help of anti-factor 10A. And how we used to monitor this unfractioned heparin, so with the help of APTT. So like target APTT ratio should be 1.5 to 2.5. 6 hours after the initial dose, then we should monitor after 6 hours of every dose adjustment. Like initially we should monitor after 6 hours, then in every 6 hours we used to monitor it. Then they are telling like subcutaneously, if we are giving this IV, with the route of IV route, then this is that was the dose. But if we are giving it with the subcutaneous mode, then initial dose of 333 unit per kg followed by 250 unit per kg every 12 hours. Okay, guys. Then like without and we can give subcutaneous unfractioned heparin without APTT monitoring. So then comes like fondaparinux. So this is a synthetic pentasaccharide, and it binds with antithrombin 3, which is which causes inhibition of factor 10A and inhibition of thrombin generation. And they are telling half-life of approximately 17 hours, excreted almost completely by the kidney. What are the other oral factor 10A inhibitors? So they are telling like rivaroxaban is there. Rivaroxaban is like uh, given in prophylaxis or treatment. Action start within 3 to 4 hours. There is no requirement of monitoring. It is metabolized by liver and excreted in the urine. Other examples are apixaban. It is compared with vitamin K antagonist, and like fewer interaction, non-inferiority, and less bleeding risk is there. Then comes direct thrombin inhibitor, which are like lepirudin, ergotrovan. They are telling like we should give them in heparin-induced thrombocytopenia. Ergotrovan is like synthetic agent having half-life of approximately 45 minutes, and it is cleared by the liver. Then lepirudin is recombinant polypeptide similar to heridin. It is having half-life of 60 to 40 to 60 minutes, and it is cleared by the kidney. So lepirudin is cleared by kidney, ergotrovan is cleared by the liver. Continuous intravenous infusion and monitoring of the APTT we should done. And then comes the dabigatran. Dabigatran is orally available direct thrombin inhibitor. So this is the summary of direct oral anticoagulant which is approved for management of pulmonary embolism. So these all are like 10A inhibitors, and dabigatran is direct thrombin inhibitor. So yeah, we can see this apixaban is there, which is factor 10A inhibitor, 10 milligram BD dose is there for 7 days. Then we should give 5 milligram BD dose. And there is no need for like parenteral therapy at initiation. Then they are telling extended therapy dosing after initial 6 months. They are telling like we can reduce it till 2.5 milligram BD. And study name is Amplify study is there for apixaban. They are telling like there is reduced risk of 2.3% of this VT, and like major bleeding rate is 0.6%. And they are telling like we should avoid it if creatinine clearance is less than 15 ml per minute. Then comes rivaroxaban. It is also factor 10 inhibitor. Dose is 15 milligram BD for 21 days, then 20 milligram daily. Parenteral therapy no required at initiation. We can give it after 6 months. We can give with the dose of 10 milligram daily. And Einstein P. Einstein P study is there for this rivaroxaban. It used to reduce the VT risk is only 2.1% with this recurrence rate is only 2.1%, and major bleeding risk is 1.1%. While with the warfarin, bleeding risk was 2.2%. We should avoid it if creatinine clearance is less than 30 ml per minute, and it should be taken with rivaroxaban should be taken with food. Very very important. Rivaroxaban should be taken with food. Then comes edoxaban. Edoxaban is also factor 10 inhibitor. 60 milligram daily dose is there. 5 to 10 days of parenteral therapy is required at initiation. No data on dose reduction is there. Hokusai VT. Hokusai VT is the study for edoxaban. Uh, Recurrence rate of VT is 3.2%, while with warfarin is 3.5%. And major bleeding risk is 8.5%, but with warfarin it is 10.3%. And we should avoid it if creatinine clearance is less than 15 ml per minute. Then comes direct thrombin inhibitor, which is like dabigatran. Dabigatran dose is 150 milligram BD, and we should give at initiation 5 to 10 days of parenteral therapy. There is no data on dose reduction is there. Recover study is there for it, and like VT recurrence rate is 2.4%. Major bleeding rate is 1.6%, while with warfarin it is 1.9%. So like it is more than it is less than warfarin only. And we should avoid it if creatinine clearance is less than 30 ml per minute. So less than 30 ml, we should avoid dabigatran and rivaroxaban, and less than 50 ml per minute, we should avoid apixaban and edoxaban. And we should avoid if dyspepsia or GI symptoms are present, we should avoid dabigatran. Then comes warfarin, very very important. So now comes warfarin. So warfarin is vitamin K antagonist, as we already know. It inhibits gamma carboxylation activation of coagulation factors second, 7, 9, 10, as well as protein C and S. This is very very important point. So it is also inhibiting protein C and S, and it is used to inhibit the gamma carboxylation of these factor 2, 7, 9, 10. Then they are telling like when these VKs are used, anticoagulation with unfractionated heparin or low molecular weight heparin or fondaparinux should be continued in parallel with oral anticoagulation for more than 5 days, and until the international normalized ratio value has been 2 to 3 for consecutive 2 days. So like vitamin K antagonist, if we are using them, if we want to use warfarin, then initially we should start it with this unfractionated heparin or low molecular weight heparin till 5 days. After that, if PTNR is between 2 to 3 days, then we can start warfarin. So what are the things about this warfarin? So it is having narrow therapeutic index, very very important. So we should monitor it closely with the help of the INR. Targeted INR should be between 2 to 3. Side effects are like it can cause bleeding complication, it can be teratogenic, it can cause skin necrosis or paradoxical. Drug interaction could be there like alteration of absorption, like cholestyramine. So it used to interact with the cholestyramine. Then they are telling about the induction of hepatic enzymes like CYP450. It used to cause induction, and like so it used to interact with barbiturate carbamazepine. With the help of inhibition of CYP3A4, it used to inhibit amiodarone. Obviously, like amiodarone will not metabolize properly. Then it used to inhibit CYP2C9. Then so it used to do interact with metronidazole and clotrimazole metabolism. Then displacement of the protein bound warfarin like phenytoin. It used to do increase anticoagulation action like broad spectrum antibiotics, ceftriaxone, erythromycin, chloramphenicol, aspirin, sulfonamide, phenytoin. With these all drugs, it used to increase the anticoagulation action, and like decrease anticoagulation action will be there with the help of barbiturate, carbamazepine, rifampicin, griseofulvin, or oral contraceptives. So like dose adjustment is required in the elderly or malnourished, liver kidney failure, alcoholism, malignancy, recent history of gastrointestinal bleeding or trauma. Then comes thrombolytic therapy, very very important. So like this vitamin K is available with in the form of acetone. Then comes thrombolytic therapy. So like it causes direct lysis of thrombi by increasing plasmin production through the plasminogen activation. And greatest benefit within the 48 hours of symptoms onset, it can be useful for 6 to maximum 14 days. Increased risk of bleeding, increased intracranial hemorrhage from 0.3 to 3% cases. Thrombolytic therapy is recommended for high risk of pulmonary embolism cases, very, very important. So it is recommended in case of high risk pulmonary embolism. Then rescue thrombolytic therapy is recommended for patient with hemodynamic deterioration or anticoagulation treatment. So these are the thrombolytic regimen doses and contraindication. So first thing is like this recombinant tissue type plasminogen activator (RTPA) is there. So they are telling like we have to give 100 milligram over 2 hours, then or like 0.6 milligram per kg over 15 minutes. So maximum we can give 15 50 milligram dose. Then what is the dose of streptokinase? So they are telling like 2.5 lakh international unit as a loading dose over 30 minutes and followed by 1 lakh international unit over 12 to 24 hours. Then another regimen is like 1.5 million international unit over 2 hours. Okay, guys. So yeah. Then comes urokinase. Urokinase we can give 4400 international unit per kg as loading dose over 10 minutes, followed by 4400 international unit per kg per hour over 12 to 24 hours. And accelerated regimen is like 3 million international unit over 2 to 4 hours. So we should give 3 million. Urokinase and streptokinase 1.5 million. So what are the contraindication to fibrinolysis? So what are the absolute contraindications? So history of hemorrhagic stroke or stroke of unknown origin is there, then we should not give this thrombolytic therapy. Or ischemic stroke in previous 6 months, central venous system neoplasm is there, major trauma, surgery, head injury in previous 3 weeks, bleeding diastasis is there, or active bleeding is there. So in all these cases, we will not do fibrinolysis. Then there are like relative risk. So transient ischemic attack in previous 6 months, oral anticoagulation, pregnancy, or postpartum week, non-compressible puncture site, traumatic resuscitation, refractory hypertension is there, like more than 180 mmHg. Then advanced liver disease, infective endocarditis, or active peptic ulcer are there. Then we should not do like this is the relative contraindication for fibrinolysis. Then comes percutaneous catheters. So insert catheter into the pulmonary arteries via the femoral route. Obviously, different type of catheter like ultrasound, mechanical, pharmacomechanical, or standard catheters are available. May combined with local thrombolytic therapy. We can combine them. Alternative to systemic thrombolysis or surgical embolectomy for treatment of pulmonary embolism. These catheters are like alternative. So risk for paradoxical embolism is there. Contraindication in patient whom an intracardiac communication is already there. So we should not give this percutaneous catheters. We should not use these. Then comes surgical embolectomy. So persistent hypotension, shock, cardiac arrest, who either failed thrombolysis or have contraindication to thrombolytic management, then we should do surgical embolectomy. Surgical pulmonary embolectomy is recommended for patient with high risk pulmonary embolism in whom thrombolysis is contraindicated or it has failed. Very, very important. So this is very selective number of population whom surgical embolectomy is required. Like patient is high risk pulmonary embolism and thrombolysis we can't do. Then comes surgical embolectomy in acute pulmonary embolism is usually carried out with cardiopulmonary bypass without aortic cross clamping and cardioplegic cardiac arrest, followed by the incision of two main pulmonary arteries with removal or suction of fresh clot. So here we can see this is the example of available suction embolectomy catheters. So first one, this A is angiovac system is a large bore 26 French aspiration catheter requiring a centrifugal pump. It requires a centrifugal pump. This is the centrifugal pump and the return cannula is there. So yeah guys, then comes this is the flow retriever system. It uses 22 French aspiration guide catheter with syringe for suction and a catheter with nitinol disc for mechanical disruption of thrombosis. So these are like discs which used to mechanically disrupt the thrombus. Then this is the Numera aspiration system. It uses a small bore catheter. It is like 6 to 8 French catheters with separator wires are there. So yeah, And like they are telling, it used to mechanically disrupt the thrombosis, uses automated aspiration system. Then comes vena cava filters, mechanically prevent venous clots from reaching the pulmonary circulation. IVC filter should be considered in patient with acute pulmonary embolism and absolute contraindicated to anticoagulation is there. They are telling IVC filters should be considered in case of pulmonary embolism recurrence despite therapeutic anticoagulation is there. So there are two conditions: either there is contraindication to anticoagulation, or embolism is present despite therapeutic anticoagulation. So then in those cases we will use vena cava filters. So these are like this is the example of retrieval and inferior vena cava filter IVC filter. So, what is the bleeding risk? So, they are telling with vitamin K antagonist or with warfarin, there is 3% annual incidence of bleeding, 40% reduction in the risk of major bleeding with this NOAC compared with vitamin K antagonist are like with advanced age or previous bleeding if no associated with reversible treatable cause or anemia or active cancer. Then previous stroke or either hemorrhage or ischemia is there, chronic renal or hepatic disease are there, or like they are telling like concomitant antiplatelet therapy patient is using or non NSAIDs should be avoided if possible. Other serious acute or chronic illness is there, poor anticoagulation control is there, then will bleeding risk used to be there. So like how we should follow up the patient with acute pulmonary embolism. So if we are giving anticoagulation, we should follow up for at like 3 to 6 months at any time. So they are telling if dyspnea or functional limitations are there or not, we should check it. If it is not there, then we should assess risk factor for is there any risk factor for chronic thromboembolism, pulmonary hypertension. So this is like a different flow chart. We should not read it now. They are telling like yeah guys. So this is the like PADS-P study which demonstrate the high long-term risk of recurrence of this venous thromboembolism is there or not. So yeah, this is the estimated cumulative risk. So this is the placebo. This diagram is the placebo diagram. Patients with placebo. This is patient on warfarin. So we can see like long-term risk are very used to be less in patient with warfarin than compared with placebo. So very important. So this is the risk assessment tool for unprovoked venous thromboembolism recurrence after cessation of anticoagulation. So there are multiple risk assessment too. We can check them. There is HERD 002 DAS risk assessment tool. Then Vienna prediction model and Ottawa prediction model is there. So these all models are for like risk assessment. So this was all about the